I think the most critical point that we learned over the last few years is that therapy should be individualized, with HbA1c targets below 7 as the regular target and more stringent targets in young subjects without cardiovascular disease and more loose targets in subjects with higher age or comorbidities. And in addition to that, we learned that we should avoid side effects such as hypoglycemia or weight gain. Yeah, so for years we haven't seen trials reducing cardiovascular events with antidiabetic drugs, but only recently the EMPERIC outcome trial testing empagliflozin, an SGLT2 inhibitor versus placebo, showed a reduction in cardiovascular events driven by cardiovascular death and hospitalization of heart failure. In addition to that, liraglutide, an SGL1 analog, also reduced cardiovascular events in the LEADER trial. The mechanisms are unclear, but as far as we know today, it's not glucose lowering, or at least not glucose lowering alone, but additional effects such as weight loss, reduction of blood pressure, and as of yet unknown effects might have contributed to the results. Well, there are a couple of cardiovascular outcome trials coming, trials with the agents that I mentioned, SGLT2 inhibitors and GLP-1 analogs. In addition to that, a very interesting trial is the Carolina trial comparing linagliptin, a DPP-4 inhibitor, versus sulfonylurea, so challenging our current concept that the second important drug after metformin is sulfonylurea, and we're testing, or the study is testing, whether linagliptin may be more beneficial here.